So before we start working out what we can do to help prevent our migraine attacks and reduce the severity and intensity, I think it's really important that we actually understand what migraine is. So a lot of us have been given this diagnosis and sent from the doctors with some medication and still don't have a really clear understanding of what is actually happening in our body. But before we discuss migraine, let's discuss headache and how, when you do go off to your doctor, how they diagnose what type of headache you have. So there's an international classification of headache disorders, and I've put the link on the slideshow there. And it's very complex. There's a lot of different diagnoses in there. But what we like to do is separate them into primary headache and secondary headache. So if we skip down to secondary headache first, this is a headache that's associated with another medical condition. So the other medical condition comes first, and then headache is like a byproduct or a side effect of that condition. So I've put some examples down there. If you've got secondary headache, you definitely need to be seeing your doctor and getting that primary condition treated. So primary headache is not associated with another medical condition. It's a headache that includes migraine, tension headache, cluster headache, cervicogenic or neck headaches, and many others as well. So it's a disorder on its own, and it's its own entity, if you like. Now, you've probably read the stats that it's thought that 15% of the world's population suffer from migraine, and it is more likely in women. But the most common type of primary headache is tension headache. And we all know what tension headache feels like. It's that band, usually due to stress or muscle tension. It's generally mild or moderate, and it often comes every day. The head and neck muscles are always involved, and stress is usually a factor. So many people with migraine also experience other types of headaches. So you're more predisposed to getting these types of headaches as well. So like tension headache. So I often use the analogy of asthma. So asthma is a clearly understood condition. And if you've got a friend or someone you know that has got asthma, you know that it's a condition that they're living with. And one day they may have no symptoms, another day they might be slightly short of breath, and then on another day they might be having an asthma attack, which can potentially even put them in hospital. Some of them are taking preventative medication every day. Some of them don't need preventative medication but have acute attack medication on hand. So you can see the analogy with migraine. It's exactly the same. Migraine is a disorder that we're living with every day. It is a condition. Some days we might have no symptoms. Other days we might have minor symptoms like a tension headache. And then on other days we might be in a full-blown migraine attack, which, like asthma, might even send us to hospital. Some of us are on preventative medication, depending on how often we get our migraine attacks, and others just have acute medication for when those attacks do happen. So I think trying to understand it and using that analogy of asthma really helps people understand that it's a condition that we're living with. It's always with us, even when we're having an attack. So just before we go on, I think it's really important for you to read through this list. We call them red flags. So if you have any concerning symptoms, particularly any new symptoms or new symptoms associated with your headache or new headache or a new type of headache or any of these others that are on the list, then it's important to go and speak to your medical doctor and just ensure that your headache or your migraine attack is not associated with another underlying disorder. Now, the majority of people I see with migraine have been diagnosed many years ago, and they've been living with it, and their attacks come and go. The pattern might change, but it's quite predictable and consistent. This is more for people that have got new headache or are new into the diagnosis, and we just need to double check to make sure that you're on the right track and that there's nothing underlying. So now to migraine. What is it? Well, we know that it's a disabling primary headache disorder. But what it is, it's a neurological disorder, and it's often genetic. So you might find that there's other people in your family, your mum, your sister, your grandma, like in my case, have all got migraine. So there's a lot of genetic studies being done at the moment to try to find out exactly what gene it is, but that's not conclusive. It's also a sensory processing disorder. That means the migraine brain processes things differently. Basically, we have got a sensitive brain. Our migraine brain is sensitive to smell, noise, sound, the works. And then once we're triggered, there's a cascade of events that results in a huge variety of symptoms. Headache, which is that usually unilateral and pulsing pain, is only one of the symptoms of migraine. A migraine attack can last for a long time, so it can be short, just a few hours, or it can be days. And some people have symptoms that persist between the attack. We call these interictal symptoms, and often these are that hypersensitivity, the sensitivity to sound, smell. It's always with them. So when we have a migraine attack, there's lots of changes that are going on in our brain. There's chemical changes leading to inflammation, vascular changes, which gives that throbbing, and electrical changes, which gives that hypersensitivity. And this is all happening in the brain, and this is why we have so many symptoms. And it's important to note here, there is no cure for migraine. Just like there's no cure for asthma. It's a condition that we have, and it's a condition that needs to be managed, and there's a lot we can do to manage it. There is obviously the route of medication, which you will talk to your doctor about. There's acute and preventative medications, but there's so many lifestyle things that we can do, and that's what you're going to be learning about in this course. And our goal is to keep those migraine attacks at a minimum, and when they do come, they're less intense, they're less severe, they're less frequent. So I love this little diagram here, and it's really great to give to people that you're trying to explain migraine to. Migraine is not headache. So you can see headache. Headache is when you have a pain in the head or an ache in the head. Migraine, yes, we get our head pain, plus we get all of these other symptoms potentially and more. And the trick with migraine is everyone is different. So, you could have 10 people that have migraine, they've been diagnosed with migraine, and they all have a different story, different symptoms. And that's what makes it so hard for treatment. So when you go off to the doctor and, in the first place, and they diagnose migraine, they're using the guidelines of the International Headache Society, and that states that you need to have experienced 5 headaches that meet these criteria. So unilateral pain, pulsating pain, moderate to severe intensity, and accompanied by nausea and vomiting or sensitivity to light and sound. And I know from my experience, and I'm sure for yours, we're definitely ticking all of those boxes. So I thought I'd just quickly go through the phases of migraine. So this is the phases of a migraine attack. So before we get to the pain stage, we normally go through a prodromal stage. And these can include symptoms like yawning, food cravings, stiff neck, mood changes. You might be feeling a little bit grumpy. Things like this, and they're different with everybody, but it's really important if you can keep your headache diary and tune in and know when you've got a migraine attack starting, then that is when you can do your treatment and it'll be much more effective. After prodrome, we move into the aura stage. So only about 30% of people experience aura, and it's commonly visual issues, and they can be all sorts of different visual issues. It can be flickering, it can be spots, it can be like, you've got dirty glasses on, that sort of sensation. People describe very different things with their visual aura, but aura can also include tingling, weakness, and speech difficulties. And again, if you're getting to this point, this is when, if you're taking medication, the time to take medication, but we will talk later in the course about a migraine attack plan. This is when we want to put this into place so we can nip it in the bud. Next, we go on to that acute stage that we all know too well. And this is when the pain comes and all those horrible symptoms, the nausea, the vomiting, the dizziness, all that sensitivity. Once that acute stage has passed, we go into a postdrome or a hangover. And it really just feels like a traditional hangover, as though you'd been drinking the night before. You're tired, you're fatigued, the mood changes are there, you're just not feeling like your best self. And then once you pass out of that, you're out of the migraine attack and you're back into the interictal. So interictal is between attacks, but as I said, many people do have heightened senses all the time. So we call these interictal symptoms. Now, you'll be diagnosed when you go off to the doctor as either having chronic or episodic migraine, and how the medical management differs depending on if you're considered chronic or if you're considered episodic. So basically, you're considered to have chronic migraine if you're having more than 15 migraine days a month for 3 months. If you're less than this, you're considered episodic. So episodic tends to be treated with attack medication, whereas chronic tends to be treated with preventative medication. So about 3% of people shift from episodic to chronic, and making lifestyle changes, the ones that you're going to learn with me, can really decrease your risk of becoming chronic. So the longer you've been in that chronic stage, the harder it is to shift back to episodic. But if you are chronic, it definitely is possible to shift back to episodic. And that is going to be our number one goal for those of you who have chronic migraine. You are more likely of becoming chronic if you have other comorbidities. So for example, if you are overweight, if you have asthma, if you have mental health conditions, chronic pain conditions, and sleep disorders. So if you have any of those, we need to make sure they're getting treated as well. Otherwise, you are more likely to shift from episodic to chronic, and we certainly don't want that. So we've spoken already about the interictal symptoms, and just to remind you, it's usually the sensitivity. So sensitive to touch, sound, light, heightened smell, and other symptoms like that. And this is because our migraine brain is a sensitive brain. And it's really important to remember that our brain is not the same as other people's brains. And it did take me many years to accept this fact. I would look at my friends and the things that they could do and get away with. And it would be hard. Like, why can't I, miss out on a few hours sleep and not get away with it, or have a glass of wine and not get away with it, and all of these things. But once you come to accept that you've got a precious migraine brain and we have to treat it carefully, it's like having, if you had a Ferrari car, you'd put only the best fuel in it and you'd look after it really well, compared to if you had a cheap car that, you thought, oh, I'm only going to have this car for another year. It doesn't matter. I won't look after it so well. It's that analogy of we need to look after ourselves a little bit more than other people, because we just won't get away with it if we don't. So what causes migraine? So we know it's a genetic condition. We're wired for it. We've got a migraine brain, and we'll use this term a lot throughout the course. And there's a lot of debate in the literature, but it's pretty much accepted now that it's caused by an increased excitability or a sensitization of the central nervous system. And this migraine brain is hyperexcitable or sensitive all of the time. And then we can make it more or less sensitive depending on what we're doing throughout our day, our lifestyle. And again, that's what we're going to be learning. We're trying to decrease the sensitization of this migraine brain that we have. And that is when we will see ourselves getting less migraine attacks. So it's interesting for you to know about the brain stem. So our brain goes down into a little stem that goes to the third cervical vertebrae, so the third one down from the top of the neck. So it's like a little tail or a little stem. And this is where all the nerves from the body come up and they go through this brain stem, and then they go up to the brain for the brain to interpret what they're saying. So this is the area that can become hypersensitive or sensitized. And when it's sensitized, all those messages coming from the body are getting amplified. So it's like turning up the volume, and the brain's getting all this information in this amplified state. And of course, that's what's triggering our migraine. And the brain doesn't know that it's getting amplified. It thinks that all these messages that are coming up are accurate, but it's actually just because it's going through this little sensitive brainstem. The brainstem, the technical term for it is the trigeminocervical nucleus. So you might hear me mention that throughout the course. When we get a migraine attack, depends on our threshold. So I love this little diagram. We've spoken about our migraine threshold a little bit already, and we'll talk about it again when we're talking about triggers. But the important thing to know is that we've got a sensitive brain, but how sensitive it is depends on what we do. So we end up having a threshold where when we pass that threshold, we get our migraine attack, and that threshold can move up or down. We can't make it go away because we've got a migraine brain, but we can make it more or less sensitive. And the less sensitive it is, the higher our threshold to migraine. And if we've got a high threshold to migraine or a less sensitive brain, we can get away with so many more of our triggers before that attack strikes. So I think, we'll talk about this more, but this threshold theory is really, really important. And this is what we're going to work on. Rather than trying to discover all of our triggers, we will talk about that as well. I would prefer you to have a higher threshold so the triggers become a little bit more irrelevant. So there's just a little graphic. By changing our lifestyle and decreasing our triggers, we can move our threshold and change how probable it is that we will get a migraine attack. So let's talk a little bit more about this brainstem or this trigeminocervical nucleus. How does it become sensitized, and how can we make it less sensitized? So we're going to talk about a lot of the lifestyle changes. So as you know, I've developed the 6 seeds of success, and these are the 6 primary things that we can do to decrease the sensitization. But why is it sensitive in the first place? We know we've got this genetic condition, which is giving us this generally sensitive brainstem, but it can become more or less sensitive. The first thing is the dysfunction in the first 3 levels in your neck. So the first 3 levels go up and feed directly into this brainstem. From 3 down, those levels are feeding down into our body. So this is why a lot of people feel neck pain, and why if you've got any neck dysfunction, it makes you more probable to get migraines. And this is what my work as a physiotherapist, when clients come to see me in clinic, this is what I'm working on. Predominantly these first 3 levels in their neck, making sure they're in the right position, that they're moving freely, that we've got good function. And we'll go over some exercises that you can do at home that will really support these first 3 levels in your neck. The other nerve that feeds into the brainstem, or the trigeminocervical nucleus, is the trigeminal nerve, which is our 5th cranial nerve. And any dysfunction in any of the structures that this trigeminal nerve supply will also sensitize the brainstem. So some of the areas it supplies is the ear, the jaw, the teeth, these chewing muscles, your gums, sinuses, face, eyelids, eye sockets, nose, tongue, and your nasal mucosa. So there's a lot going on there. And if you think about the areas that you might be feeling pain, this is why. Because the trigger, the trigeminocervical nucleus, it doesn't know what is sensitizing it. So it just sends pain out to all those areas. So this could be why we have eye pain, why we have visual dysfunction, why we have neck pain, ear pain. Even though there's nothing wrong with those structures, those areas are in pain because of this trigeminocervical nucleus. Now, sometimes there is issues in these areas, and that can trigger this. So if you do have any problems in those areas, then you should go off to the appropriate practitioner. So eyes, for example, go to the optometrist, get your eyes checked, make sure everything is working well. Ears, nose, go off to the ear, nose, throat specialist. The jaw, the teeth, you might go off to the dentist. So it is worth going through that process and getting all those areas cleared to make sure that there's nothing actually feeding into that TCN and making this problem worse. The third thing that can sensitize it is if we've got low brain levels of serotonin, and we're going to be talking about serotonin a lot. The research shows that people with migraine have altered brain chemistry that predisposes them to headache, and one of these is low levels of serotonin. And we will talk more about this, what we can do. There's lots of things, as you can see there: meditation, exposure to sunlight, exercise, diet. We're going to go through this in detail. If we can boost our levels of serotonin, then we can settle down that sensitization. So we can work on looking after our upper neck. We can work on looking after all those structures that are supplied by the trigeminal nerve, and we can work at boosting our serotonin. And all of these things are going to decrease the sensitivity of that brainstem, and then all the messages that are coming up through the body will no longer be amplified and will no longer trigger a migraine attack. So we are going to raise our threshold to migraine. We are going to decrease the sensitization, and we are going to learn about our triggers and try to avoid those as well. So next up, we're going to talk about triggers. And remember, triggers are not the cause of your migraine disease.